Good morning, everybody. I'm going to go ahead and get started here. I'm going to discuss anterior cervical arthroplasty. I'm currently a spine fellow at the Hoag Orthopedic Institute, and we'll get started. So some indications. So generally, younger patients with soft disc herniations, minimal segmental spondylosis, preserved motion at the index level. The class And the classic patient would be a radiculopathy from a single level soft disc. So here's AP lateral radiographs, 37-year-old with a C5-6 soft disc herniation causing C6 radiculopathy after failed non-operative care. Radiologic assessment, X-rays, evaluating facet arthropathy, osteophytes, any listhesis or instability. MRI and CT to confirm soft disc pathology, assessing any neural compression, estimating implant size, including height, width, and depth. And key concepts involve significant facet arthropathy, osteophytes, listhesis, which are all relative contraindications. In terms of preoperative planning, arthroplasty system is available, but always having an ACDF set up as backup ready. Consent should include possible intraoperative conversion to a fusion once you get in there, and then it's a standard anterior cervical exposure. So exposure and localization, confirming perfect lateral fluoroscopic view before prepping. Poor visualization can be a relative contraindication. Localizing the level with a needle and then or using the vertebral body placement if you're uncertain, so you don't mistakenly insert the needle into the wrong disc. So these two lateral intraoperative images show adequate lateral visualization, which is mandatory for appropriate implant positioning. So the initial decompression setup, removing anterior osteophytes with a Lexel bone wax for bleeding, cast bar pin placements, which must be midline, and this is more critical than in ACDF. Gentle distraction using a cob and a distractor, and using about 2 to 3 clicks based on the disc tightness. So image over there to the right shows controlled distraction through cast bar pins to restore the disc height. Your discectomy technique involves the standard annulotomy and then starting at the uncus, moving midline, repeating along your superior end plates. Disc removal using curettes, pituitary, and Kerrisons, and defining your coronal goalpost, which is your uncus to uncus. And the key principles here are to fully expose the disc space before any implant work. End plate preparation, so you burr anterior osteophytes and creating a flat surface. The cephalad end plate is often more concave, so it requires more preparation. Preserving cortical end plate bone, removing posterior osteophytes, and preparing the posterior portion of your vertebral body. So image to the right shows end plate preparation, extending posteriorly for a full decompression and to allow for appropriate implant seating. Some critical concepts. So the goal is to create flat parallel end plates, and you must have visualization from your uncus to your uncus, which are your goalposts. So this can be more demanding than ACDF. There's some implant-specific nuance. Dome-shaped implants may require less preparation. And then they utilize the RASP here for their final prep image to the right prior to trialing. So the decompression philosophy can be viewed as more aggressive than foraminotomy for an ACDF, and the reason is that this is a motion-preserving procedure, so there can be residual compression post-operatively that can become symptomatic. So you should pay extra attention to fully decompressing your nerve roots, removing posterior osteophytes, and then PLL if indicated. Next step is the implant trialing. So you release your cast bar distractions before trialing. The trial should fit snugly and not require forceful impaction. So the goal is to avoid overstuffing, which would cause facet overdistraction. And then utilizing fluoroscopy to ensure your disc heights matches adjacent levels. So image to the right shows the trial, which restores physiologic disc height without causing overdistraction of the facets posteriorly. So there's system-specific techniques, drill guides or cutting guides. The critical principles are the same, that they must be centered perfectly. So you confirm with an AP before setting in your final implant. So images here, lateral intraoperative images showing the cutting guide positioned centrally for your channel creation. And then final implantation. So you irrigate your disc space, remove any bony debris to reduce any chance of heterotrophic ossification. Insert your implant and then confirm your positioning once again on the lateral for your depth and then your AP to ensure that you're centered perfectly. In terms of postoperative management, no cervical collar to encourage early range of motion, and motion preservation is the goal of this procedure. In terms of some outcomes, motion preservation, so goal is to maintain segmental motion, reduce adjacent segment stress. So this procedure requires proper indications, precise technique, and a complete decompression. So final postoperative X-rays show maintain alignment, and then flexion and extension films in the bottom show preserved motion at the index level. Thank you.